Welcome everyone to our webinar on the 2026 Medicare Final Rules, what it means for RPM and CCM. Since 2018, CMS has steadily expanded remote care coverage, making RPM and CCM core components of chronic care delivery. The 2026 final rules bring important updates that directly impacts on how these services are delivered and reimbursed. Today, we're joined by Rob Sanchez, our expert in RPM, CCM, and CMS policy and reimbursements. Rob will break down the major changes, the new RPM CPT codes, reimbursement parities, and concurrent billings for RPM and CCM, and also outline the steps providers must take to maximize their reimbursements while staying compliant. If you guys have any questions, feel free to ask within the Q&A option in the chat, and Rob will address them either within the chat or once the webinar is over. Rob, the floor is yours.
All right. Thank you very much, Mustafa. Happy to be here talking about the 2026 Medicare final rules and what's new, how they'll impact us, how they're going to impact our providers, what to look for, and give you all the new details surrounding these new CPT codes. A lot of exciting and new rules that are going to be beneficial for the growth of RPM and CCM. Just as a reminder, we will be recording this. So Mustafa, please make sure that we're recording this. I'll have this available. I'll share my contact information at the end. So for those of you who want a copy of this, you can call me, text me, email me. I'll share all the details so that I can send this to you afterwards. Happy to meet anybody for a call or a coffee. We'll make it happen, help you guys out. So as many of you guys know, my name is Rob Sanchez. I see a lot of our clients on the webinar today. So welcome. Thanks for joining. I'm the Chief Business Development Officer for Proactive Wellness. I've been in the RPM space for a very long time, since way before there was any reimbursement, going back to about 2011. So I've seen this space grow. I've seen it utilized in various fashions, from 30-day all-cost hospitalization. How do we curb that? How do we manage patients from chronic conditions, where we're at today? So this is exciting that some of these rules have been changed for the betterment of not only what we can provide for the patients, but what we can do for our partners and the business behind the world of healthcare. So let's jump into this. As Mustafa mentioned, if you have any questions, punch them in that Q&A. We'll try to address them near real time as we go along. Otherwise, we'll knock them out at the end here. So there's a lot that we're going to dive into today, and why this conversation is so important right now. First, we're going to take a look at RPM and CCM, why it continues to grow year after year. This isn't a temporary trend. It's driven by real pressures in the primary care space. It's driven by rising chronic conditions, more volume in that perspective, and the CMS push towards a more value-based care. Providers are realizing that they simply can't manage complex patients the old way anymore. We'll also get into key updates for 2026. Not just RPM, but CCM and RTM as well. CMS introduced a level of flexibility we haven't seen before. You're going to see how these changes make it easier for us to bill, for us to get these thresholds, and make it more practical in a real-world care environment. We'll also touch on reimbursement parity. This is a big one. This is one that's near and dear to my heart, because I've been fighting and pushing for this for a long time now. CMS essentially is leveling that playing field so that remote care services are valued more consistently across the board. That stability matters when you're planning growth or when you're evaluating these programs. So it's worth that to see if it's worth that operational lift. So we'll talk about that. From there, we'll talk about how all these changes impact you guys, the providers. Some of these are impactful from a finance perspective, some are from an operations perspective, and then some of ours are going to be strategic. We'll talk about that. We'll share with you what's getting easier, what still requires structure, and why having a strong partner like us matters more than ever. And then finally, we'll end with the practical side of things, what you need to know to stay compliant, to maximize reimbursement under these new rules. Everything from documentation, time tracking, consenting your patients, making sure that the workflows are aligned with CMS expectations. So my goal for you today is to leave with clarity and not confusion, and make sure that there's a clear sense of how you can take advantage of these new opportunities without overwhelming your staff. So before we go any further, I want to give you a little history on RPM and CCM. So why does it keep growing? So practices are drowning in chronic disease volume, and RPM CCM services finally give us that real support that we need. To put things in perspective, 6 out of 10 patients or adults are now living with at least one chronic condition. 4 in 10 have 2 or more chronic conditions. I bet if I take a poll right now to all my providers that are out here right now, they'll probably say these numbers are very conservative, and that's probably true. These are numbers from the CDC. Payers are doubling down on value-based care, and RPM and CCM quietly checks off those boxes, reducing things like readmissions, catching issues early, improving adherence to medications, to their therapies, documenting these touch points that are going to be necessary in between office visits. So this directly fuels the quality scores and shared metrics that ACOs kind of keep expanding for and pushing for. So these programs become less optional and more of a kind of expected or a must-have. So practices are realizing that they're leaving both money and outcomes on the table. As many of my clients out there know, when I've talked to you in the beginning and we talked about and got you through onboarding, I see a lot of my providers out there, with all due respect, peace and love, they step over dollars to pick up pennies. I want to make sure that we help you identify how to not only provide that amazing quality of care that the patients deserve and that you're able to provide them, but also recognizing that behind all of this, you're operating a business, right? So these are tools and resources that you need to have in place so that you can be as efficient as possible. And that's the type of value that we can provide for you. And any other, and some, not any other, but a lot of quality service providers like us. There are several out there. But it's important that we identify kind of what to look for. And I'm gonna point those things out as we go along. Lastly, it's one of the revenue streams that grows while improving patient outcomes. Most new programs either will cost you money to implement, an investment of some level for equipment, for more staff. RPM and CCM will do the opposite, right? They bring that predictable monthly revenue that your business operator is looking for, little overhead, and the patients actually get better. That's why adoption keeps rising. It's predictable income, measurable improvements that we're able to offer. So there's no upfront burden to your clinic, to your staff. Providers are finally seeing that they can scale these services without having additional headaches as a program becomes more prominent within their service operations. So jumping into the codes themselves. So a lot to unpack in this slide. I'll start first by saying there's 3 key elements that are new. Number 1, they made a permanent virtual supervision. So what does that mean? Before, it was direct supervision. Then they moved it to general supervision that allowed companies like us to do the work for you guys. And that was kind of back and forth by CMS. They were playing around with removing it. They were playing around with going back to direct. Direct meaning that you had to be in that doctor's office to provide these types of services. So that was a non-starter, very challenging. Why? Because it pretty much meant that the office themselves had to provide and do these types of programs. And the reality is, with all the moving parts that you have on a daily basis, probably 9.5 out of 10 don't have the bandwidth or the expertise. Not only that, it's going to cost you a lot more to put the staff with that expertise in place to manage these programs day to day. So CMS has been taking a close look at this for the last 3 or 4 years. The way they take a look at it is on a yearly basis. They put the proposed rules and they wait for comment from companies like us, leaders like us that get out there and give the feedback to Medicare, to CMS rather. They finally listen, right? I've been in HIMSS committees, I've been in PCHA committees where we pushed for these types of changes, and I'm so glad to finally see some of these taking place now. That it's going to make life a lot easier, just in terms of checking the criteria or the threshold criteria to make this service applicable for so many patients out there today. So permanent virtual supervision is one key critical point that is now permanent. So the rule that I want to clarify is the incident to billing. So pretty much all this says that is that incident to lets us do the day-to-day RPM work under your general supervision and under your MPI, giving your clinic the revenue without adding additional staff workload. You're going to hear me keep kind of saying that throughout this webinar because it's a critical piece. So allow so this will also allow concurrent documentation of RPM and CCM. So that's been going on for the last few years as well, where you can provide RPM and CCM for the same patient, except though you want to make sure that those times are clearly separated and there's no overcross on those minutes. I'll talk a lot more about that here as we move it to the next slide. But the reimbursement parity is the other item that is new for 2026. These new codes offer shorter monitoring periods that will reimburse at the same rate as the existing codes that the longer periods are done. So this will encourage right-sized care plans for certain patients. And then RTM expansion into medication adherence and behavioral health is another aspect that enhanced the offering for RTM. So with RTM, we also will have the same parity rules and the same shorter cycles of delivery that will be provided for these patients. The codes are going to stay the same, are 4 core codes for remote patient monitoring. The first one is 99453. That covers one time for onboarding the patient, providing them the device, going over it with those patients. For us, we will call that patient as an intro follow-up within 24 hours of getting that referral. We have a one-time call with that, not one-time call, but this one-time bill for that conversation, which is the onboarding and training. All of that gets documented. We're able to bill that at the end of the month. Then we've got 99454, which is the monthly reimbursement for the device, supplying the device, the technology, the data transmission. Think of all the IT stuff behind the scenes. For this one, CMS requires 16 days of data being transmitted, 16 days of data in a 30-day period. So that was monumental for many patients. Now, the new code is 99445, which allows for data be transmitted at a minimum of 2 days to 15 days. So for a long time, if we had patients that only got us 15 days of readings, we were 1 day short of being able to file for billing that claim, which meant we would eat that cost, and that was the risk that we would take as a company. Now, as long as we've got everything documented, which you can rest assured that we do, we'll be able to file for either of those CPT codes at the end of the month. The other codes, 99457, 99458, remain the same. Those are the ones that talk about our clinical time period spent with the patients. So the first 20 minutes are 99457, then each additional 20-minute increments are covered under 99458. For anything less, sometimes we do spend less time with the patients. That will be covered under 99470 for the first 10 to 19 minutes of monitoring time. Each of these codes require a two-way communication with the patients, okay? So those are some of the elements that we'll take care of, that we document, that we ensure that we've got the proper documentation within our system and within your EMR system on a monthly basis, okay? For RTM, the codes they simply focus on non-physiological data. So we're talking musculoskeletal conditions such as rehabilitation for total hip, total knee, respiratory conditions such as COPD. We do have the COPD module coming up, so we're really excited about that. So anybody interested in COPD, you can talk to me afterwards. I'll bring you up to speed with where we're at in RTM and COPD in the coming future. Okay, but these are the key points. So the impact on providers, what does this mean? CMS is basically signaling that the future is an integrated care, not siloed services. With the new ability to stack RPM and CCM and medication management codes, practices can finally capture that full value of the work they're already doing. When these programs are layered together, it only strengthens the clinical oversight, but also meaningful increases in recurring revenue per patient each month. So secondly, shorter time period captured is now reimbursed. So this is incredible, something that myself and so many others have been fighting for a long time. So it's great to see this finally coming through because it only makes sense. So for a long time, companies like us would outlay the capital for equipment, for the data transmission, and sometimes, man, we'd fall short. We wouldn't get paid on that. So for those of you who are out there that are on the fence about RPM and kind of know that there's a lot of expenses behind the scenes to put these programs into place. They are beneficial, but they do come at a cost. And so many times companies like us that want to do the right thing for the patients, this is the type of stuff that we do to help get these programs off the ground. So to me, this was a big one. And then thirdly, operationally, as I mentioned earlier, we want to do right by the patient. And on the other hand, we also need to make sure that our operation from a business perspective are also sharp and in place. So these new codes now gives the practices some breathing room. So instead of forcing every patient into the same billing rigid kind of structure, CMS now allows for these care plans to be tailored to actual patient needs. So introducing these codes brings more flexibility, but the flexibility does not mean simplicity. Practices still need a team that can operationalize these workflows every single day. So we got to tailor the care plans. We need to manage the data. We need to continue with the patient engagement. We need to document our clinical minutes. We need to stay ahead of the compliance requirements. And that takes a dedicated infrastructure. And that's kind of where programs like us come into place, where we can make that happen. Most clinics don't have that capacity or capability in-house to do so. So that's important for us to recognize. So our model lets you capture the expanded reimbursement without adding that staff, chasing documentation, or risking any denials. The rules may be easier, but the work is still tough, right? Lastly, scaling these programs. So the new rules absolutely make RPM and CCM more financially sustainable rather, but it doesn't mean it isn't the same as scalability, right? I want to kind of be clear about that. Most practices still struggle with the day-to-day lift. And what do I mean by that? You got to remember, I got to recruit the patients. I've got to onboard the patients. I got to monitor the data. I got to document the time. You got to close loops with tasks associated with kind of a trend that you've been seeing with a patient. Make sure that you follow up with them on a timely basis. So you got to have a nice tight compliance, and that's challenging. So that's the part that breaks internally, and what changes really do open the door for these programs to scale is that this flexibility that we've just been talking about. So we make this now possible for the clinics to grow these programs without hiring more staff and bringing more burden onto them, which is ultimately what turns that sustainability into actual growth. So compliance highlights. So with the new RPM and CCM codes, CCM hasn't relaxed the compliance requirements. Every billed minute must be documented. Every data point must be captured correctly, and every patient interaction must meet engagement thresholds. That level of precision is hard to maintain in a busy clinic. When you outsource, you're not just buying support, you're buying consistency, that audit proof, documentation, and the team whose only job is to make sure every claim meets CMS standards. So that's where we'll come into place and ensure that that's taking place month over month. That's the difference between programs that exist and a program that can survive the audit and get paid month over month. Okay. Secondly, patient consent. Got to consent every single patient, got to have the proper order and consent the patient. Nothing's changed there. We just want to make sure that that's on every chart. Thirdly is ensure clear workflows. So one of the biggest compliance risks in remote care programs is accidental duplication. I mentioned this briefly earlier, multiple teams with documenting the same minutes, overlapping services, or inconsistent notes. So CMS is watching out for this type of stuff. Without clear workflows, clinics can trigger denials or worse, audit exposure. So we want to make sure that when you outsource, you're doing this in a structured program like ours that's going to make sure that we keep our records clean and have everything centralized so that it can eliminate duplication and protect your revenue and keep your programs audit ready month over month. All right. So here's the money slide. So everybody that I talk to, they always want an example of the billing, how it works, what does it look like. I'm going to try to keep it very simple. Kind of two avenues now that we've got these flexible CPT codes available and in place. First, we've got the one-time billing code 99453. As I mentioned, one time when the patient comes on service, that reimbursement is about $20. So depending on where you're at, we got a lot of people that probably all over the US. It's going to be dependent on your MAC. So if we call me afterwards, we can look up your MAC and I can give you sharper, more pointed numbers in terms of how much the reimbursement is in your neck of the woods. $20 is about the average. These are all national averages. The next code is going to be 99454, which is going to be the device supply and data transmission. Reimburses about $48. Now, keep in mind the other code, the new one that I mentioned, 99445. Sorry, a little bit of a tongue twister there. That reimbursement for anything less than the 16 days of readings is going to be the same. So it's going to be $48 either way. But you can only bill one or the other, not both. Then it's going to be the time spent by our clinical team. This one, straightforward. The first 20 minutes reimburses at about $48. So now, when we add both those, our reimbursement's up to $96. Third code available, if I spend 40 minutes or more, that code is $39. So now we're about $135 a month. If I spend 60 minutes or more, now we're at $174 a month of reimbursement. Okay. Keep in mind, everybody asked me this, how many of these codes can we keep applying? Only up to a max of 2, so 60 minutes worth of data points. But that should not apply for all your census across the board. Okay, so be really careful about that. I know there's some providers out there that are going to be very aggressive and go down the line and everybody gets 60 minutes of care. That is a huge red flag, my friends. Please be careful about that. There's no way that they can do that. So so I'll be happy to share kind of the usual percentage of how many codes people tend to hit. I'd be happy to share that offline with you guys. Now we've got an option, right? Now we've got either you've got a full 20 minutes or more, which you would go on, the first column, or under 20 minutes. So for a long time, if we had patients that we only talked to about, let's say 12 minutes, we couldn't bill for that. Now we're able to bill for that. And the reimbursement on that is $26. So 26 and 48, that reimbursement for this patient would be $74. So given the level of work and the right sizing for these patients, now we're able to bill appropriately, a little bit tighter. So it gives us that flexibility. For CCM, it's a little bit more straightforward. There's only 2 flavors of CCM, regular CCM and complex CCM. With regular CCM or non-complex CCM, it starts with CPT code 99490. It reimburses at a rate of $65. That's the other upside, by the way. There was an increase of about 2.5 percentage points plus for CCM. Okay, so you will see these reimbursements actually go up. So that's kind of nice compared to the haircuts we've been taking year over year for the last few years across the board and just in the world of healthcare alone, which is sad. 99490, one code, $65 first month. That's for the first 20 minutes. Additional 20-minute increments, reimbursed at a rate of $46 per month. You add that up, you're at 111. You can do another 20 minutes, you're at 157. Okay. Now for complex, it's a little bit different. Complex, it becomes complex when we hit 60 minutes or more. Okay. Now with complex, now it's taking a lot more time that our nursing staff spends with either the patient, resources, other providers. There's a lot of care coordination that takes place with CCM. So as I tell my clients, the key difference is going to be RPM requires a device. CCM does not require a device. It requires a care plan. It requires goal setting with the patient. Think of it as more a blend of the clinical and social needs associated with managing your patients. So many times patients go to your office, they have other problems outside of their acute condition, for example, or their chronic condition, and who are there, they need some of these resources and some of these tools. Sometimes these offices just don't have that expertise in-house. So great opportunity to turf that to us where we can help that patient offline per se and make those dedicated phone calls. So as an example, our nurses will do a lot of research behind the scenes. We've helped patients in other areas of the U.S. find transportation to their doctor's office visits. We've helped families find adult diapers at an economical rate in other next parts of the country. We've helped patients that were not able to make it to their doctor's office routinely because we learned that they were in a wheelchair, and during days when his nephew wasn't around, he missed those office visits because he didn't have a ramp. So behind the scenes, our nurses would collaborate with the insurance companies, the insurance care managers, and then they would also talk to local resources, and together they found a solution to build this gentleman a ramp. So now he wouldn't miss his office visits. So a lot of social needs that CCM, that we can provide your patients for CCM and again, remember, you got to keep them tied to your clinic so that you can have that scalability that I keep talking about. But going back to my flow here of following kind of the CPT codes and revenue. The first CPT code, if you spend 60 minutes on a patient, is 99487. The reimbursement rate on it is $135 per month. If you spend 30 minutes more on this patient, so if you go from 60 to 95 minutes, let's say, I can now bill 99489. So that adds another $70 of reimbursement. So it tallies up to 205. You can do this multiple times as long as everything is documented. Don't be surprised if sometimes we've got a 2.5 hour conversation with a patient and management offline. We're able to bill for all of those as long as it's all medically necessary and we've got everything documented, which is what we always provide at the beginning of each month for you guys within your EMR. So that's CCM, complex and non-complex. So why providers should act now? Look, first of all, starting RPM and CCM now means better outcomes and better predictable revenue. Every month that you wait is revenue you can get back. Early adoption simply gives your practice a head start. Your patient base grows, your recurrent income compounds, and your practice becomes stronger and more financially stable. That's what we want. We want to be able to help you from those two perspectives: good patient care and giving you more financially stable revenue. Second, stronger patient relationships lead to direct higher retention. So a lot of competition in the world of RPM, a lot of competition in the world of where do I go my PCP, right? We want to make sure that they're coming back to you and staying loyal to you. So we are a resource for you, for your offices, for your practices, so that we can help you already continue to provide that excellent care that you're already giving your patients. So when the patients feel supported through RPM and CCM, they stay engaged, they trust the practice more, and they're far more likely to remain long-term. These programs give you that consistent touch point, and strengthen that loyalty, to reduce kind of those sudden drop-offs. Lastly, CMS continues to double down on care coordination across every major payer model: ACOs, primary care initiatives, and chronic care programs. They're rewarding organizations that stay close to these loops, that document consistently, and keep these patients engaged in between visits. But real care coordination isn't just a billing rule, it's an operational engine. I want to be clear about that, right? Most clinics don't have the bandwidth to run this engine internally. That's where a dedicated partner is critical. So we'll give your practices that infrastructure to meet CMS expectations every month without overwhelming your staff. And that's exactly what keeps these programs financially sustainable and audit ready. So, um, 3 adoption and lead driving options. So what to look for as you shop for RPM or CCM vendor in 2026. We've had a lot of interest over the last few months. You know, as companies, practices are closing their year, closing their quarter, they're very busy with patient care, but they're also planning for 2026. I want to be able to be a resource for you guys. So our physician partnership model removes the 2 biggest barriers from adoption. That number 1 is going to be operational lift, and number 2 is the billing complexity. So a lot of billers, a lot of billing companies are not used to billing for RPM. It has a lot of little nuances, the timing. They're used to billing. They're used to seeing claims come in on a daily basis, and you bill for that. With this, it's all done in a monthly arrears. So we'll track that for you guys and provide a nice tight billing report for your clinics on a monthly basis. So clinics get a turnkey management engine that runs in the background. So what does that mean? We want to be able to produce real clinical value. We want to generate consistent monthly revenue for you, all without disrupting your workflow, right? So that's where the adoption starts to increase. We try to make it simple and compliant at the same time. We want to feel like an extension of your practice rather than you guys stopping what you're doing to implement us, right? We want to be able to jump right into the workflow with you, and that's what we'll do when we start these programs with our practices. So by managing that entire RPM and CCM operation under the NPI, going to number 2 here, which is our physician partnership model, we let the practices participate fully in the reimbursement opportunity without adding the staff and building additional workflows. So again, I've talked a lot about it. We want to take that compliant risk off your table and help smooth everything out so you can launch these programs. And then finally, value-based readiness strategy. So every practice, independent or part of an ACO or an affiliate, you want to make sure that you already have your value-based strategies in place. You want to make sure that you have something like this in place to help tighten those screws. So we're not just running a monitoring program. We're helping you build a value-based engine. Our model will align will align and address HEDIS, MIPS, and ACO quality goals and incentives. So every touch point strengthens your performance in those metrics. And what we'll do is we do quarterly business review meetings so that you can see how the program is growing and enhancing that care. All right. We've got about 5 minutes or more, probably a little over 5 minutes for any Q&A. I want to share with you my contact info. The number there is my cell. You can feel free to call or text me. I encourage you to scan that QR code. It'll lead you to a little form where I can share this slide deck with you. Happy to connect over a call, over coffee if you're local. I'm here in Dallas. Happy to learn a lot more about, your clinic, your practice, and help you launch your next RPM or CCM program with us. With that, I'll pause. I'll send it over back to Mustafa for Q&A.
Thank you so much, Rob, for this insightful session. We have two questions with us. One of them is asking, how much of my clinic time is realistically required each month? I want to participate, but not add another layer to an already packed schedule.
Can you repeat that first part, Mustafa?
Like, how much of my own clinical time is realistically required each month?
Oh,
I want to participate, but not add another layer to an already packed schedule.
yeah, very common concern. So for providers, look, you're gonna be seeing these patients. So kind of the way to slice this up is when you go and see your patients, you identify the patients that are going to be good for, let's say, a hypertension control program. I want to put you in this program, which involves taking your blood pressure on a daily basis and monitoring your trends. That explanation is usually done within that time spent with the patient. We will have devices in place for you where your MA can give the device, and then the patient can go on their way. The instructions the MA will give is probably about 2 minutes worth. Here's the device. Here's the contact information. Anything goes wrong, we will handle all that. We will onboard all your clinics so that they're comfortable with the process, and it's very, very easy. On a daily basis, when we get these readings, we are triaging, coaching these patients day in, day out, right? So as we get high alerts, we're addressing them. Our nurses reaching out and making sure that it's a legitimate alert. Sometimes there are false positives, so we will triage that and make sure that we flesh out all that noise. So meaning we will work with you ahead of time to create the protocol specific to your workflow. If you want, I've got providers that want us to call them directly. I've got providers that say, call my MA with any alerts that need addressing. So once we identify that we do have an alert, we'll call that MA, for example, and then from there, they will take it from there. From time to time, we do get situations where it does require an ED visit. Our nurses are going to be there to document everything and send the patients to the proper care. All of this continues to be documented. Okay, so remember, this is not an emergency hotline. So that's kind of one thing that providers are always nervous about. It's like, I don't want to be blitzed with a lot of blood pressures. That will not be the case, I can assure you. We will provide you the monthly data points so you can see that probably less than 1% of the time are we reaching out to you. And that's based on a lot of data points that we get throughout the course of the month.
All right, Rob, super. Another question comes from one of the viewers. They say that, hi, my concern is patient engagement. What happens if patients don't transmit readings or don't answer calls? Does that affect billing or clinical responsibility?
Yes, good question. So this is kind of where the flexibility comes into play. So before, it was 16 days of reading or more. That was part one. Part two was spending at least 20 minutes of care on the patients, right? That was a phone call, managing data behind the scenes. If we didn't hit at least 20 minutes, we wouldn't be able to bill for that. So now those thresholds have been lowered, which really helps us out a lot because now we're able to capture a lot of that. But to answer your question, what happens in the situations where we're not able to engage the patient and the patient takes the device home and never uses it, for example, it will happen, unfortunately. But there's no repercussions for our providers when it comes to that, right? Because if we're not able to bill, we're not able to file a claim. We're not billing anybody for that. We'll call the patient. We make sure we do our best effort to try to engage the patient. When we bring a patient on, we want to make sure that they understand that this is a program to help them with their blood pressure control, with their diabetes management, right? So it's not just random phone calls, it's actual coaching, it's actual going over DASH diet, it's actual going over medications. So the patient gets to understand the reason why this program is beneficial. So we work really hard to educate them and give them nuggets of education as we go along. And what we found is when we create a program like that, the engagement goes through the roof and they're on the program for a longer period of time. So bottom line, if they don't engage, don't worry, you're not getting billed for it. That's on us. That's the risk that we take on. But we do our very best effort to have a high engagement rate so that we do the right thing by your patients and the right thing by your business.
Alrighty, thank you so much for that detailed elaboration of the answer, Rob. I see that we do not have any more questions as of the moment, so I'll just sum the entire webinar up. The key takeaways from the 2026 final rules are simple. CMS is rewarding integrated care models. With code stacking and aligned reimbursement, providers can now have an access to revenue flow out of reach. Early adoption is essential to secure these gains and strengthen your patient engagement and help you take advantage of these changes. Offers several strategic pathways, including our turnkey enrollment campaigns, physician partnership models, as well as value-based strategy for your practice only. Do contact us from the information if you have any further information. This webinar is going to be uploaded onto our social medias as well. And thank you so much for joining us today. And
Thank
with
you.
that, let's end the event. Thank you, everybody.